Good evening. So sorry for bit delay because I wanted to do this class in YouTube live stream because there are so many students who wanted to listen this class again even after the class. Not only the students, also some doctors. Not some, most of the doctors, even my registrars wanted to listen this. Hi, good evening. So sorry for bit delay because I wanted to do so most of the doctors, so that's why uh, it got delayed to arrange that one. Okay, so welcome to this class. Actually this is another one of the difficult topic in gynecology, and very important topics, not only for the exam, also for your clinical practice, right? So not only in Sri Lanka, so all over the world we are doing this screening system for the cervical CA, right? uh, so will it be available on YouTube after this class also? Yes, it will be available because as a lot of students asking me to keep it in, and a lot of doctors also asking me to keep this one in the YouTube. I'll keep for some few days to watch this video because this is one of the important topic, right? So in gynecology, the cervical screening and emerging topic in Sri Lanka, right? So when you come to the exam, you will get more question on this, not only for the ERPM, also for the local students, undergraduate students, and postgraduate students. Yes, we in postgraduates also nowadays they are putting these questions, the cervical screening. So we should know the importance of cervical screening first, right? So why the cervical screening? And second thing, you need to know the prevention of cervical screening. Why prevention of cervical cancer? So why we are doing this screening, right? So then of course, so it's going to be a very interactive and very interesting class, right? So you might not have much knowledge, sometimes you might have knowledge, but sometimes you might have confusion on this, right? So I hope to explain the screening today, right? So if possible, we will discuss something like management of uh, uh, precancerous lesion as well, right? So if time permit, we will do. Otherwise, first we'll concentrate the screening, how we are screening, right? Okay, so meantime, if you have any doubt, yes, feel free to ask doubt. Yes, I'm here to explain everything, right? So some of students request me to do the obs-gynae ethical practice in obs-gynae also. So I'll do that soon, because last time ERPM exam also there were some question about ethical aspect of obstetrics and gynecology. uh, Actually we can't cover all kind of theories or theory topics in the paid session, so I'll continue to do these things until we complete this obs-gynae theory, right? So hopefully you will get advantage, and you will understand the obs-gynae, and you will get through this exam, right? Fine, first we'll start the topic rather than talking much. All right, so what do you know about cervical cancer, right? So any idea about cervical cancer? Actually the cervical cancer is one of the major cancer in females next to breast cancer, right? So in females, the commonest cancer are cervical CA, breast CA, endometrial CA, right? So among the other cancers, right? Among the other cancers like cervical CA, so the breast CA and the endometrial CA, the cervical cancer has some good quality. Of course, the cancer is not good, but among the other cancer, the cervical CA has good quality. So it's why I'm telling this is, right? This cervical CA, it's almost 99.7 percentage, right? Keep that in your mind. Almost 99.7 percentage is due to a virus, right? A virus. What is that virus? What is that virus? Yes, yeah, it's an HPV, right? Human papilloma virus. So this HPV is an STI, right? So sexually transmitted infection. So what is the message you are understanding from here is, as it is a STI, as it is a viral infection, if you can prevent this viral infection, right? So this HPV also like a coronavirus, like a polio virus, right? So other virus, so influenza virus. So if you can prevent this viral infection, you can prevent the malignancy. Do you understand? You can prevent the malignancy. So as it is a viral infection, as this malignancy caused by virus, you can prevent the infection. Prevent the malignancy. So prevention is possible in malignancy. That is one. Second thing, from the viral infection to conversion of malignancy, right? So from the viral infection to conversion to malignancy. So the normal tissue is converted as malignancy. Give me 1 minute. So the normal tissue is converting as malignant tissue. So from the normal tissue to viral malignant conversion, it takes time, right? So it's has a long latent period, right? It has long latent period. So from the malignancy to normal cell to malignant tissue, it has long latent period. So what is the advantage of having long latent period? So during this conversion, you can find it. Say for example, so we are going to discuss about the normal cervical epithelium, then what is happening, what is the pathophysiology, what is happening once the HPV infection occur, right? So then how it is converted into malignancy. We are going to discuss that today. So when you see the malignant transformation, so initially what will happen, this normal tissue will convert it as pre-malignant lesion. So with kind of abnormal tissue, those abnormal tissues are not really malignant. Those are not really normal tissue. Do you understand what I'm telling? They are not really malignant. They are not really normal tissue as well. So those abnormal cells will convert it to malignant cells. So it's kind of intermediate cells, right? So what I'm trying to say is, right? So if you see a cervical epithelium, right? So this is the normal cervical epithelium. It might convert it to malignant tissue. Yeah, you can see it's an abnormal tissue. So this is the malignant transformation. But usually what will happen, this normal tissue will convert it as intermediate cell. This is called pre-malignant cells. These pre-malignant cells will convert it as malignant tissue. So these pre-malignant cells can be converted to malignant cells, or it can revert back to normal cells. Both are possible. But if you have a pre-malignant cells, the risk of malignant transformation will be high. Say, for example, if I have normal cervical epithelium, so the malignant transformation risk is less. But if I have a pre-malignant tissue, the malignant transformation is going to be high. Do you understand? So the target of screening is, we are looking the cervical epithelium in the pre-malignant lesions. We are searching before they become pregnant, before they become malignant. Once you find the pre-malignant lesion, you just remove the epithelium. You just remove the epithelium. Once you remove the epithelium, there won't be any malignant transformation. So you can prevent it. Okay? So you can prevent the malignant transformation. So that's why the cervical cancer can be preventable. So if you see the Western world incidence of malignancy, actually the cervical malignancy incidence has been dramatically reduced, because they are doing a lot of preventive measures. They are doing a lot of preventive measures, not like Sri Lanka. So still, very sad to say, in Sri Lanka, 70% of patients are presenting to hospital with a cervical CA in late stage. In late stage. Because the awareness about the prevention, awareness about the screening is poor in Sri Lanka. Right? So that is the aim of cervical CA screening, cervical screening. So actually we are screening for the pre-malignant lesions, and we do intervention to prevent the malignant transformation from pre-malignant lesion to malignant tissue. Do you understand what I'm telling? So these preventive measures can be primary prevention, right? Or secondary prevention or tertiary prevention, right? Primary prevention, secondary prevention, or tertiary prevention. Primary prevention, secondary prevention, tertiary prevention. So what you understand by primary prevention? So the primary prevention means, right? So the primary prevention means, so as we discussed a bit early, this cervical CA is due to HPV infection. Cervical CA is due to HPV infection. So if you can prevent the HPV infection, so then there won't be any abnormal transformation in the epithelium. Agree? Yeah, you can prevent the abnormal transformation. So we are targeting at the beginning. From the beginning, you are preventing the infection. So the measures to reduce the HPV infection is the primary prevention. Do you understand what I'm telling? So if you can stop the HPV prevention, then there won't be any abnormal transformation. So I can explain you why this abnormal transformation. So in pathophysiology, we are going to explain, because you should have that knowledge. Then only we can simply understand the rest of the screening process. So first I would like to say what is prevention, what is screening, what is sensitivity, what is specificity. So then only we can talk about those things, right? So because always you keep in your mind, you all are doctors. You are not here to pass the exam. You are not advanced level students. So you should have a knowledge, right? So you should know what is pathophysiology, what is screening, what is sensitivity, what is specificity. Those kind of things you might study in community medicine. Anyhow, I'll revise in obs and gynae subject as well. Do you understand? Right. So primary prevention, we are targeting to stop the transformation, or targeting to stop the malignancy from the beginning. So we are inhibiting the infection of HPV. So what are the ways? How can you prevent the infection? How can you prevent the HPV infection? What are the ways? The measures, whatever the measures we are doing to reduce the HPV infection is primary prevention. Say, for example, safe sexual practice, right? So, having sexual relationship with one person. So if you have a relationship with one person, then you won't get the chance to get the infection from others, right? Safe sexual practice. So using some barrier method like condom during the sexual practice, right? So the important one, so as the all viral infection, if you are immune to the particular virus, then you will not get any infection. Agree? So you have to get the immunity for the particular virus. How can you get the immunity? By immunization. So that is called HPV immunization. Now you might heard that, right? So HPV immunization is in your EPI schedule, right? So immunization. So all over the world, by the immunization, they could reduce the cervical CA by 70%. All over the world, they reduced by 70%. But still in Sri Lanka, we started very recently, right? So we need some time to reduce it, and we have to make aware among the public regarding the immunization. So immunization, right? So what is EPI? EPI is expanded program of immunization, right? So safe sexual practice, so using barrier method, immunization, those are primary prevention. So what do you understand by secondary prevention? Secondary prevention means now the infection has occurred, the malignant transformation and malignant process already started, it's going on, but still it is not converted as malignancy. Still it is not converted as malignancy. So until it converted as malignancy, it is going to be asymptomatic. Patient will not have any symptoms. That is called preclinical lesion. Preclinical lesion. What do you understand by preclinical lesion? Before they develop symptoms. So when somebody develop malignancy in the cervix, then they will have symptoms. What are the symptoms? They might have postcoital bleeding, cervical mass, right? There might be ulcer. Or sometimes the malignant tissue might spread to adjacent tissue like bladder or rectum. So then they might have bleeding into the urine. That is called hematuria. Sometimes if you have a malignant spread into the rectum, then during the defecation, they might have bleeding, PR bleeding, right? That is called clinical lesion. Here, we are targeting to find out the preclinical lesions. That is your pre-malignant lesions. So I'm going to explain you what are the pre-malignant lesions. So if we can find the pre-malignant lesion, preclinical lesion, then you can stop the progression of malignancy. Agree? Nimashi, do you agree? Right? So we are targeting the preclinical lesion and we stop in the preclinical lesion. We don't let the tissues to become malignant. Do you understand? Right. So that is your secondary prevention. So most of the cervical screening, there are so many methods of cervical screening we are going to discuss now. All these cervical screenings are secondary prevention. We are targeting in a pre-malignant lesion and we found in a preclinical lesion and we remove the tissues. Then there won't be any progression. Okay, that is your secondary prevention. Now, we have a question, why we are doing screening? Why we are doing screening? So what is screening? What is screening? Why we are doing screening? So as we discussed earlier, this is your normal epithelium. This is your malignant tissue. So the malignant transformation will occur through a steps. Initially, the normal tissue will convert it as abnormal tissue. Then abnormal tissue will convert it as malignant tissue. So we are targeting to find out this abnormal tissue, and once you diagnose the abnormal tissue, once you find the abnormal tissue, you do some intervention to destroy or remove the abnormal tissue, then you can prevent this transformation. You can prevent the malignancy, right? That is called screening, right? So as we discussed a bit earlier, these abnormal cells, these pre-malignant tissues are preclinical stage. They don't have symptoms. So as it is a preclinical stage, right? So most of the people might have this preclinical lesion. We don't know. So how do you know? What is the best way? What is the best way to assess whether they are having normal tissue, whether they are having abnormal tissue, whether they are having malignant tissue? How can you confirm it? Yes, Pragit, how can you confirm it? Whether it's normal, whether it's abnormal, whether it's malignant, how can we confirm it? How can we confirm it? So what we have to do is we have to take a piece of tissue, not pap smear. So if you want to say, yeah, this is abnormal, then what you have to do, you have to take a piece of tissue from the cervix and see under microscope whether these cells are normal or abnormal or malignancy. Do you understand? So you need to take a piece of tissue and see under microscope whether is it normal or abnormal or malignancy. So taking a piece of tissue, from an organ, how do you call that process? That is called biopsy. That is called biopsy. So for the confirmation whether it's normal or abnormal or malignancy, for the confirmation, you need to take a piece of tissue. So now, out of these 404 students, maybe 200, 250 girls are there. Right? Out of these 250 girls, maybe 50 girls might have preclinical lesions. Right? We don't know. Right? So, because there is a common infection in a sexually active woman. So, if I want to check whether they are having preclinical lesion, so then what I want to do, I want to take entire 250 girls and take a biopsy, give anesthesia and take a biopsy from the cervix. Is it possible to do that? So if I want to screen or if I want to check whether this woman, so in Sri Lanka, maybe around 10 million women are there. So out of this 10 million, maybe 10,000 people might have preclinical lesion. So to find the 10 million people, 10,000 people, out of this 10 million, there might be 100 cervical CA patient. Out of this 10 million, to find out this 100 people, am I going to take the biopsy? Am I taking all these 10 million women to the theater, give anesthesia and taking biopsy? Is it possible? No, it's not possible. So ideally what I want to do, I want to take a biopsy. I want to confirm it. But unfortunately, you can't do that in a practical way. You can't take each and every woman to the theater. You can't give anesthesia to each and every woman, and you can't take a biopsy from each and every woman. That is not possible at all. So then what you can do? Then you can do some measures to find out the people who are having high risk, of having the abnormal cells. Do you understand? Right? So out of these 200, there are 50. So what I am doing is, I am doing some simple measures which can I do among these 250 people to find out the high-risk patients, high-risk people, screening. Do you understand? Screening method. Say for example, so out of these 404 students, I need to take only 20 students to the internship. Right? So I'm going to take only 20 students to the internship or maybe some training program. For that, how can I select these 20 students? Can I select somebody I know? Okay, Dushan come, Pragit come, Lakshi come. So I can't select on my own. So then what can I do? I can do an exam. I can arrange an exam. Right? I can arrange an interview. So then I can set the cutoff, right? So if somebody get more than 85, or first 20 people who got highest marks will be enrolled into that program. So what I'm doing, I'm screening some students, right? I'm screening the people among this population, this student population. I'm screening and I'm looking the very intelligent guys by the exam. Do you understand? So the purpose of doing is that to find out the intelligent guys. But there are some issues in that screening. Say for example, if Lakshi has problem with husband today, then what will happen? She can't perform well in the exam. So that exam will not be 100% correct. That will not show 100% her intelligence. Agree? Sometimes she might have migraine today. She might have nausea, vomiting today. So then she can't concentrate. She can't do the exam properly. So because of the exam, I said, no, you are not eligible, but actually she might be eligible. Do you understand what I'm telling? So the screening test has a problem. It can have false positive reports, right? False negative reports as well. Sometime when I am doing the exam, so by chance, right? So Prageet might show some topics, that topics came to the exam by chance. Then he did well. Or sometime Prageet might somehow he got my paper, so he did some fraud and he got through the exam and he selected. So that doesn't mean Prageet has I'm just telling your name, right, Prageet? I know you are very intelligent, but I'm just telling. So Prageet has mistakenly taken into that program. So that is a wrong positive. Sometimes wrong negative. So we have a problem when we do the screening test might be positive, false positive, as well as false negative. Do you understand? So there are several ways to do the screening. So what can I do? I can do a MCQ. I can do SBA. I can do essays. I can do interview. So different test has different level of negative value. So for example, if I do MCQ, right? So that will not affect your handwriting. Sometimes, so for example, my handwriting is very poor. So if I am writing the essay, then even I am writing all the important information, the examiner will not read and he can't understand what I have wrote. Do you understand? So then I might fail because of my handwriting, but that doesn't mean I am not eligible, right? So if it is an MCQ, that handwriting part will remove. So if it is a direct interview, I am just having an interview with some other exam panelist, right? So then, so when the candidates or maybe some people are coming for the interview, so if it is a very beautiful girl and smiling nice, so then she might get more marks. Yeah, agree? I don't know. There are possibility. So sometimes there might some people might have good knowledge, but their language might be a barrier. They don't know how to speak in English. Sometimes they might be very intelligent, but they don't deliver. They don't know how to deliver their knowledge. Do you understand? So there are different factors might affect the screening of the real people. Do you understand? So different methods have different level of ability to find out the correct person. Do you understand? So the same thing is applicable for this cervical screening. So we are using different kind of screening. So as it is screening, what is screening? So among the population, we are doing some feasible test to find out the high possible people. Do you understand? So among those high possible people, high risky people, then we can do the confirmatory test. We can do the biopsy. We are not going to do the biopsy from everyone. So while you are doing the screening test, there are risks. You might miss really abnormal tissue. Agree? Because your screening test might do mistakes. Still, you might miss. You might miss. Sometime you might find some people as abnormal cells, but that might not be abnormal. Sometimes they might have normal tissue. So if screening test positive, that doesn't mean they are having abnormal tissue. Do you understand? If the screening test is positive, that doesn't mean they are having abnormal tissue. Still, their tissue might be normal because your screening test is not 100% sensitive. Do you understand? 100% sensitive. It's not sensitive. There might be less sensitivity. Another condition, if somebody has a negative screening test, the pap smear, one of the screening tests, is negative. It doesn't mean that particular person doesn't have abnormal tissue. Do you understand? Sometimes she might have abnormal tissue, but your screening test say, no, it's normal. Because your screening test is not 100% specific as well. Do you understand? So you need to know the sensitivity and specificity, but you don't need to know the percentage of each and every test, sensitivity and specificity. But each and every test has sensitivity and specificity. As a undergraduate student, you don't need to know this sensitivity and specificity, honestly, right? But when you come to the postgraduate, you need to know whether it's really sensitive test or it's really for specific test. Because, say, for example, I'm asking, you are doing CRP for a patient having infection, you are suspecting infection and you are doing CRP. If CRP is high, how sure that patient is having infection? How do you know that patient is having infection? We don't know. Might be due to infection or might be due to other cause. Right? Other cause. So if CRP is normal, but still patient might have severe infection. If the patient is having immunosuppression, she might have even end organ damage, but still CRP might be normal, WBC might be normal. So that's why each and every test in the medical field has sensitivity and specificity. So the take-home message, what I'm telling is, right? So you also should know, and also you have to explain to your patient, the screening method which we are doing is screening. It's not the confirmatory test. This is not 100% specific. This is not 100% sensitive. So if you take a biopsy, that is 100% sensitive. Why? You took the tissue, you are seeing under microscope, yes, this is normal, then 100% is normal. You took the biopsy is abnormal, then you can 100% say, yes, this is abnormal. Do you understand? Right? So that is called confirmatory test. So when you come to the GDM, we are using some screening test. We are using one confirmatory test. What is the confirmatory test? That is your oral glucose tolerance test. If the oral glucose tolerance test is negative, then you can say she's not diabetes. If the oral glucose tolerance test is positive, then you can say she's diabetes. Right? But if it is a PPBS or RBS, that is a screening test. If PPBS is high, 160, you can't say she's diabetes or not. She is having impaired glucose. Sometimes it might be normal or it might not be normal. So then you need to do the confirmatory test. Do you understand? So now we are going to discuss about the screening. So the screening means among the population, we are looking for the high-risk population. Among the high-risk population, we can confirm the diagnosis by definitive diagnosis. That is your biopsy. Do you understand? Right. So if you want to do the screening test, there should be some characteristic features of screening test. So WHO has given 10 characteristic features of screening test. So I think I have mentioned all these things in your notes. So that is the best note I think you have. I send it today. Right? So you will not get these kind of notes anywhere or any books. Right? So it's combined of more than 20 books notes. Right? So everything is combined together. So if you read it, it's more than enough for you. Right? So WHO has some kind of features, given some features to the screening test. What are the features? So if you are doing the screening test, that should be easy to perform. So you should be able to do it easy. So if you want to do the screening test in the anesthesia, cutting the mother, doing surgery, that can't be a screening test. That is very difficult to perform. That is very expensive. You need specialist. So the screening test should be done in an easy way, right? Just checking the urine sugar, just checking the urine albumin. So is it a difficult process? Is it a painful process, collecting urine? No, it's not a painful process. So then it's an easy process. Then it should be very cheap. Yeah. Yeah. So you can't spend much money for the screening. So it should be very cheap. Right? So if you are doing the screening test, you should have a confirmatory test. If you don't have a confirmatory test, what is the purpose of doing screening test? No point. So if you have a confirmatory test only, then you have to screen them. Do you understand what I'm telling? Right, okay. Once you confirm, yeah, this is sin 1. This is an abnormal cervical epithelium. Once you confirm it, what is the next step? You need to treat them. So you should have a treatment modality. If you don't have treatment modality, what is the point of screening? What is the point of diagnosis? Why we are diagnosing? To treat the patient. So if you don't have a treatment modality, will you screen? Will you diagnose? No. So you should have a diagnostic modality, or sorry, you should have a treatment modality if you want to screen it. Do you understand? And you should be able to understand the disease. What is happening? How this cervical CA occur? How it is abnormal tissue? How it is occur? How it is progress to malignancy? How can we find out what can we do if we find the abnormal tissue? So if you don't know the nature of the disease, if you don't know the biology of the disease, will you screen? No. Can you screen? No. So you should know the background knowledge of that disease. Do you understand? And you should have a long latent period. So if somebody get HPV infection today, right? So if the malignancy occur within a week, can you do the screening? Can you do the diagnostic test? Can you do the treatment modality before they become malignancy? So if you have time period to do these things, yes, you can do it. Do you understand? Do you understand? So that's what. So you should have a long latent period to do screening. Do you understand? Right. So there are 10 features. You just go through the notes. Because I can't spend much time on that, because you go through the notes, right? So the screening test should have these features. And when you select the screening test, that screening test should have maximum sensitivity as well as specificity. Why I'm telling is, you can do mistakes. Everybody can do mistakes, but mistake should be less. Okay, you can't miss much people. You can't miss much abnormal tissue. So if you miss 1 or 2, yes, that is acceptable. So the test should have good sensitivity as well as good specificity. Do you understand? Okay, clear? Right. So before we move to the screening test, we will have some understanding about the histology of the cervix. So if you know that only, then only we can discuss about the screening test. So I used to teach this histology for the cervical CA as well. So just quick review of the cervix histology, and quick review about the HPV infection and what is happening. Then we will move to the screening. Okay. So actually we got a good chance to discuss this topic, because I supposed to start the theory session, repeat theory session today. But as usual, my students registered at the last moment. So within a short period, we couldn't finish before 6:30. So that's why I forced to postpone the registration process to finish the work, because the students who paid, then definitely I need to make arrangement to attend to the class, right? So then I postponed the registration. So the classes will be start soon, right? I'll inform the date, right? So like maybe next week, early part of the next week, I'll inform the date. So until that, students who can register to the course. So that's why I got a chance to do this class today, right? Because it's very difficult to find the time slot in ERPM classes. Even you can do the placenta percurita surgery easily, but finding the time slots in ERPM, it's very difficult than doing surgery for the placenta percreta. Okay, so that's why I could do it, and of course I'm very thankful to my coordinators who are helping me to uh, conduct these classes as well as registration process, especially Dr. Abhiraj Richelvam. She is doing most of the work, and also so each and every university the students are helping me to do these works, right? Especially through uh, Roshan, right? So Roshan is my coordinator and he's helping me a lot, and Ravindu, lot of people, right? So I would like to introduce them uh, as my coordinator. So they are helping me a lot. So thanks again for your support, and also please help your juniors, right, to get the knowledge. So always I'm telling to my students, please understand the ERPM future, right? So definitely this ERPM is going to be a competitive exam. This is the word I'm always telling you. People will not understand, but you will understand it later. So as a VOG, always we are anticipating the problem with the risk factors and we are ready to manage the complication. That is our policy. So we are anticipating problems, right? We are anticipating problem. So this is going to be a competitive exam, right? So now a lot of students are accumulating without exams, but number of interns going to be limited, like 250 maximum. So if you do 900 people are sitting for the exams, especially Viva, so then out of 900, only 250 is going to select in the internship. So in that case, the people who are on top, they are screening positive, will be enrolled into the internship. Do you understand? So don't think about your seniors, don't think about your friends, don't think about your relative, what they are doing, where they are going, what they are studying, doesn't matter. Think about yourself first. I'm not telling the bad thing. Of course, you have to help them. You have to tell them, yeah, this is the correct way. That is one of your responsibility. You have to teach them. Whenever you know something, whenever you study something. So today we are studying the cervical screening. You go and teach your friends. You go and teach your brother. You go and teach your relative. That's it's very important because you will understand a lot. That is very important thing. Do you understand? Right? So you need to teach them, but you have to think about yourself. What others doing? Nothing. So your senior might say, no, this is how you need to prepare, this is how you need to study. Yeah, they did the exam 2 years back. Now the entire scenario has changed. You are the one going to do the exam. You missed that golden period. Now it's going to be a competitive exam. You need to compete. You need to get more marks than Prageet to get into the internship. Then Prageet will think, no, I need to get more marks than me to get into the internship. Do you understand? That is how the world. So you prepare yourself, you study yourself, right? You perform yourself, then only you can be a doctor in Sri Lanka. That is how the scenario is going. Especially the students who are studying still, when you are come back to Sri Lanka, it is going to be a competitive exam. There is no question on that. Understand that, right? So I'm telling what is going to, yes, what is going to happen in future. So still student might not understand this fact. You will understand after 1 or 2 exams. After the 1 or 2 exams, then only you people will realize, oh my God, that person told that time, right? So most of the people are failing. That doesn't mean you might study, you are studying and your knowledge is good, but still you fail. That doesn't mean your knowledge is not adequate, but you are not enough to come in that first 250 like your advanced level. You might know the physics, you might know the chemistry, you might know the anatomy, so not the biology, but still you will not get into the biology stream, so the medical stream in Sri Lanka. Why? Because of that exam. That moment you didn't perform well. That's it. On that hour, 3 hours you didn't perform well. That's the end. Then you have to find, or you have to find another way to pass the exam. So this is the very important part. Getting the exams question, getting the answers, just studying, just doing other works and studying, it's not going to work in future. You need to concentrate, you need to study, you need to understand thoroughly all the subject, right? So once they standardize the exams, then exam is going to be tough. That is the hardest truth. If they want to limit the people, exam is going to be tough. So if you don't understand, how can you pass the exam? By chance, it's less. So how many students got through the medicine in A level by chance? Very less, until they get the paper, isn't it? But in ERPM, that chance is very less because you have to perform yourself in Viva. You have to perform yourself in Viva. That's a problem. You don't know where you are going to get the station, what is the patient you are going to get, who are the examiner, don't know. So until you are perform well, you are ready to do that, you don't have chance to pass the exam. Realize it. I will help you. I'm here to help you. I'm giving all the notes. I'm preparing notes. I'm giving the book. I'm making you to understand. So that's why I'm always telling, when I'm doing questions, I never do question and answer only. I'm repeating, explaining, giving the answer, giving the explanation, because you should be a rational doctor. Then only you can pass the exam. Giving the answer and doing. So if I do 1,000 questions, definitely out of 1,000, you will get out of 1,000. Is it difficult to get only 25 questions? Definitely the probability is high. If I do 1,000 questions, definitely you will get 10 or 15 questions out of 1,000. Then I can say all the questions I gave you got. It's not the meaning. So questions might be new, there might be some alteration, so you need to know that. So please try to understand and make use these opportunities to improve your knowledge and finish it off this ERPM, because you spend a lot, your parents spend a lot, right? Most of the parents, most of the students are from middle class. I know the value of money, right? So with very difficulties only they have given the money to make you to doctor. So please realize it and study well, and try to finish this ERPM and start earn. So even you are having problem to have the exam, whenever you have the exam, don't miss it. That is my advice, right? So and start to earn and give the money back to your parents, look after them. Because so of course some students might not think about the money because they are having enough money, they are just studying for uh, some kind of, yeah, I'm doctor for that. But most of the people are from middle class, I know. So when I was medical student, I know the value of money. I know how difficult to get a photocopied. Do you understand? So try to understand and finish it off these things during your exams, right? So you have spent almost 6 years. So you went to different country, different culture, different language. You came across a lot of difficulties, right? You also came across the difficulties. Your parents also came across the difficulties. Then don't waste another 2 or 3 years. So try to study half hard for 6 months period. If you have the exam, then finish it off everything. Do you understand? So it's a small thing. Please try to understand, and I will explain you everything, right? So don't study superficial, then you will not pass the exam. So I'm not teaching the all stuff in obs and gynae. I'm teaching the important stuff related to your exam. But those important stuff you need to know from the basics. If it is GDM, then each and everything you need to know from GDM. Each and everything you need to know from the PIH. But we are not teaching the anti-post-polypid syndrome for you. We are not teaching the posterior encephalopathy syndrome. We don't teach those very rare things to you. There are a lot of topics we never teach you. If it is a postgraduate one, yes. But for the undergraduate, few topics, but you need to know those topics very clearly. Okay, right, fine. So here, first of all, we'll discuss about the histology of the cervix. So when you see the cervix, we know the cervical epithelium is lined by two epithelium, right? So when you see the cervical canal, there are two opening, right? The cervix, this is the endometrial cavity. So the inner opening is called as internal os, right? The inner opening is called as internal ostium. Internal ostium. That is called internal os. That outer opening is called as external ostium. External os, right? So the internal os and the external os. The cavity in between the internal os as well as the external os is your cervical canal, right? Cavity is in between the internal os and the external os is your cervical canal, right? So if you see the cervix is open into the vagina. So as we know, the vagina has acidic pH. The pH of the vagina is 4, right? So when you see the epithelial covering of the cervix, right? So the inner part of the cervix is covered by the columnar epithelium, right? Inner part of the cervix is covered by the columnar epithelium. That columnar epithelium has ability to secrete the secretions and highly vascular, right? So outer part of the epithelium is covered by the squamous epithelium. Stratified non-keratinized squamous epithelium, right? So this is called squamous epithelium. Why the outer part is covered with the squamous epithelium is when this epithelium is exposed to acidic environment, when the epithelium is exposed to acidic environment, this epithelial cell will undergo necrotic changes due to acids. So if it is a columnar epithelium, that will not withstand this acidic environment. So to withstand the acidic environment, this columnar epithelium will convert it as squamous epithelium. Right? Okay. So the junction between the squamous epithelium and the columnar epithelium, this is called squamocolumnar junction. Right? This is called squamocolumnar junction. So what will happen? So when the woman attain menarche, when the woman become pregnant, right? So when they exposed to estrogen, this columnar epithelium will start to move outside. Start to move outside, right? So earlier this was the squamous epithelium. Now it's now the columnar epithelium is replacing here. But when the squamous columnar epithelium exposed to acidic environment, what will happen? That columnar epithelium will undergo necrosis and there will be a adaptation for the acidic environment. So then what will happen? What is the adaptation? The columnar epithelium will convert it again to squamous epithelium. So now you can see the one matured epithelium is converting to another epithelium. Squamous epithelium is converting to another matured epithelium into, columnar epithelium is converted to squamous epithelium. So earlier, this was the transformation, squamocolumnar junction. Now this is the squamocolumnar junction. So if you see the area between these two squamocolumnar junction, it means the actual squamocolumnar junction and the present squamocolumnar junction. This is the present squamous columnar junction. This is the actual earlier one. So if you see the area in between these two junctions, it's changing to one epithelium to another epithelium. One epithelium to another epithelium. So how do you call this epithelium? Or how do you call this zone? Yes? Yes, anyone? Tushan, how do you call that?
Transformation zones.
Yes, very good. That is called transformation zone. That is called transformation zone. So one epithelium, the covering epithelium, is converted to another epithelium. Right? That changing to one epithelium to another epithelium called metaplasia. Right? That process is called metaplasia. Due to metaplasia, one epithelium is converted to another epithelium. That is called transformation zone. So if you see this transformation zone, the epithelium is converting to another epithelium. So the changing will occur. So if you can see this transformation zone, the epithelium will necrose and new epithelium will form, epithelium will necrose, new epithelium will form, epithelium will necrose and new epithelium will form. So if you see this epithelium, your epithelium will regenerate quickly. The cell division is more in the transformation zone. Agree, Sanjeevan? So in the transformation zone, so the cell proliferation is very high. Right. Now we'll come to the HPV infection. So the HPV is a virus, so which has around 100 types of subtype of virus, right? That is called HPV1, HPV2, HPV3, HPV4, HPV5. Like that, there are 100 type of HPV viral infection. Out of this 100, around 35 subtype of HPV will infect into the genital tract, around 35 out of 100. Among these 35, right, few can change this epithelium into malignancy. Among the 35, few can change this epithelium to malignancy. How do you call that? That is called oncogenic virus. That is called oncogenic virus. What do you understand by oncogenic? Onco means malignancy. Genic producing. So malignant producing viruses. Malignancy producing viruses. That is called oncogenic virus. So the few subtypes of these viruses are oncogenic. So the common oncogenic viral subtypes are HPV 16 and 18. HPV 16 and 18. Right? So these are called oncogenic viruses. Right. So these oncogenic viruses, as we know, this virus doesn't have nucleus. Virus doesn't have nucleus. So if they don't have nucleus, what is the problem? When the viruses are replicating, they need nucleus for the DNA replication. Agree? For the DNA replication. So if I am producing my next generation, my DNA should replicate and transfer to the next generation. Then only my genetic material will transfer through the generation to generation. Do you understand? Right? So my DNA should replicate. My DNA should replicate. So the viruses doesn't have nucleus. So as they don't have nucleus, they can't replicate their DNA. So then what they can do, they can infect to a host cells. So here they are having so in the epithelium has a cell. That epithelium has nucleus. So right, if you take a cell here, this epithelial cell has a nucleus. So then what this virus will do, this virus will infect to this particular cell. Once it infect to the particular cell, the genetic material will enter into the host nucleus, okay, host nucleus. Then the host nucleus start to produce more and more genetic material. Do you understand? Right. So when you see in a human body, the cell division is well controlled. Okay. So I'm teaching from the very basic, please try to understand. So the cell division of the human cells are very well controlled. The genetic materials are very well controlled during the replications because we are having a control mechanism. But if you lose the control mechanism, what will happen? Then your cell proliferation is going to increase. You will have uncontrolled cell proliferation. So if you have uncontrolled cell proliferation in the lungs, then what will happen? There will be a collection of cells. That is called mass. Very big mass. Tumor. So whenever you lose your control in the cell proliferation, there will be a tumor formation. Do you understand? Right? So in malignancy, what is happening due to mutation, you are losing the control. So whenever you lose your control, then you will do uncontrolled works. If Sanjeevan mother and father is controlling them, then he will not do any bad thing. Once he lose the control, then he start drinking, smoking, substance abuse, everything, uncontrolled. Yeah, I know Sanjeevan is good boy. I know Janet. Oh, Sanjeevan, you are having support now from your students. Good, good. Right, I know. I'm just telling the name as he is my friend, right? Okay. So okay, Sanjeevan, you won't get angry, right? Right. So once we lose the control, the proliferation is going to be high, and there will be a tumor formation. So in malignancy, that is happening due to mutation, your cell division and your genetic material proliferation and control lost, which lead, right, which lead excessive cell proliferation and tumor formation. Do you understand? Then it's finally became as malignancy. So in HPV infection, what is happening actually, once the HPV infected into the cells, right? So they need more and more proliferation to proliferate their genetic material. Agree? So then what they will do is, once this infection, once this virus infected to the nucleus of the cells, they will stop the cell proliferation control, genetic replication control. Do you understand? So then what will happen? These cervical epithelium will become abnormal cells. How do you call that abnormal cells? That is called dyskaryotic cells. Do you understand? That is called dyskaryotic cell. Earlier, which was a normal cell, now their nucleus activity has been increased, nuclear protein content has been increased, cell proliferation has been increased, their control has been lost, and those cells become as abnormal cells. The name of this abnormal cells is called dyskaryotic cells. So when you see the cervical epithelium, if the epithelium is normal, then you can say, yeah, there is no infection. This epithelium is normal. When you see the epithelium, this one, you can see there are some abnormal feature. The nucleus is very big. Nuclear protein content is high. There are changes occur in the cells. This is called dyskaryotic changes. So if you can see a dyskaryotic changes in these cells, then you can say this cell is abnormal, right? But this dyskaryosis can be in a different stage. This can be mild dyskaryosis, moderate dyskaryosis, or severe dyskaryosis. Abnormality might be severe. So if you have a severe dyskaryosis, severe abnormalities in the nuclear protein, severe abnormalities in the cellular structure, if you have more and more abnormality, what will happen? The cell proliferation and the self-control of this particular cervical epithelium is going to last. Agree? It's going to last. Once you lost the control of cell proliferation, that abnormal cell, it's going to convert as malignant cell. Do you understand now? Okay. So the normal cell converted as dyskaryotic cell, that is your abnormal cell. That is your pre-malignant cells. So they are gaining the abnormal cell proliferation. So due to this abnormality, they are losing the control, and finally they became as malignancy. right? That's why we discussed earlier, if it is a pre-malignant lesion, there is a high risk to convert as malignancy in future. Do you understand? If it is a pre-malignant lesion, there is a high risk to convert as malignant in future. At the same time, you need to understand one, as it is a dyskaryotic cell, is due to viral infection. So if you remove this virus from the nucleus, then what will happen? Your cell will become normal. Because this is a viral infection. Because of the viral infection, it's become abnormal. Because of the abnormal one, right? So this is became as malignancy. So once the viral infection removed from the body, then your cells become normal. Agree? Right. So how the virus is removing from the body? How the virus is removing from the body? Anyone?
Immunity, sir.
Yes, immunity. So because of your immune system, the virus will be removed from your body. So in an immunocompetent woman, right? Most of the dyskaryotic cells will convert back to normal cells. Do you understand? But if a person has immunocompromisation, like HIV, diabetes, immunocompressive drugs, if a woman has immunocompromisation, or maybe malnutrition, then what will happen? Their malignant transformation and persistent infection will be high, and malignant transformation risk is high. So HIV patients are more prone to get cervical CA. True or false? Should be true. Do you understand why is it? Always you need to understand from the bottom. Because the immune system play a major role in pathophysiology of cervical CA. Do you understand? Right? Because immune system is play a major role in pathophysiology of cervical CA. So the immunocompromised patients has high risk to develop cervical CA. Okay, right? So majority of the pre-malignant lesions will convert back to normal epithelium. So in UK, in Western world, most of the people have extramarital sexual relationship. So if you do the cervical assessment in 25 years, right, at 25 years, almost 90%, more than 90% of girls will have HPV infection. But will those 90% develop malignancy? No. Only 10 to 15% of dyskaryotic cells will progress to severe form or maybe malignancy. Majority of the HPV infection will be removed by immune system. Do you understand? That's why actually the woman is sexually active in 15, 16, 18, 20, 25, 30, 30, 25, like that year. But we are starting the screening at 35 years. Why? We know in young age, majority of the HPV infection will be removed by the body. While you are starting the screening at 35 years, if the HPV infection is persistently there, it means the immune system is not removing the HPV infection, then you may have to do some intervention. Do you understand? So everything has explanation why we are doing that. Right? So if you do the HPV screening at 25 years, majority of the people might have HPV infection, then majority of the women, you will remove the transformation zone. So most of the girls will not have transformation zone. But if you don't do anything, around 90% will remove the HPV infection spontaneously without any intervention. So unnecessarily, you might do some intervention if you do bit early. That's why we start the screening bit late. Do you understand? Right? So as it is an viral infection, right? So this infection will be removed by the immune system and your tissues will become normal. If the tissues are becoming abnormal or persistently abnormal, then you need to do some intervention for prevention of this transformation from the abnormal cells to malignant transformation. Do you understand? So when you see the dyskaryotic changes, as I told you, it could be a mild dyskaryosis, moderate dyskaryosis, severe dyskaryosis. So if it is mild dyskaryosis, what do you think about the risk of malignant transformation when compared to moderate? Yes, if it is mild dyskaryosis, less. So the mild dyskaryosis has less chance to become malignant. Moderate dyskaryosis has higher chance than the mild, and severe dyskaryosis has very high chance to become malignant. So initially, the mild dyskaryosis will become moderate, then moderate become severe, then severe become malignancy. Do you understand? So if it is a mild dyskaryosis, will you intervene then? No. Actually, you don't need to intervene. You can just wait and see what is happening. Right? Majority of the mild dyskaryosis, right? Majority of the mild dyskaryosis will convert back to normal. Right? So if you are doing the screening for me, my epithelium is normal, then you are happy. Then you can do the screening after 5 years. You don't need to do anything. But when you are doing the screening to me, it's mild dyskaryosis. Then, of course, I am not normal, I am abnormal, but I am not that much severe. So then what you can do, you don't need to do any intervention, just wait and see what is happening. You can't wait for another 5 years, but you need to see me in a frequent manner, maybe in 6 months, and see what is happening. So when you see in 6 months, I progress to moderate dyskaryosis. So then you need to do some intervention because I am progressing in 6 months time from mild to moderate. Maybe another 6 months, moderate to severe. Maybe after 2 years, this severe dyskaryosis might convert to malignancy. So when you repeat it in 6 months time, if my epithelium is normal, then you are happy, right? So the immune system has been removed. You don't need to do anything. Do you understand? So this is how we are managing the intraepithelial lesions. So earlier we had a different classification. You might heard that. That is one cervical intraepithelial lesion. Right? So how to classify the cervical intraepithelial lesion, right? So don't worry, I will explain you. This is your cervix. This is your epithelium, right? So initially what will happen, the infection will occur in the lower part of the epithelium. Right? Because the lower part will proliferate much. Right? So if the epithelium occur only in the lower 1/3 of the epithelium, upper part is normal, only lower 1/3 is abnormal, then we call it as SIN1, cervical intraepithelial neoplasia 1, SIN1. Then later what will happen? This epithelium will become abnormal in the upper part as well. Now, lower 2/3 is abnormal. That is called SIN2. With time, entire epithelium will become abnormal. That is called SIN3. Once entire epithelium become abnormal, what will happen? This epithelium will convert it as malignant and it start to invade into the adjacent tissue. That is called invasive carcinoma. That is called invasive carcinoma. Okay, that is called invasive carcinoma. So this was the previous classification. Now they have changed the new classification that is called Bethesda classification. So the Bethesda classification will depend on the level of dyskaryosis. If the abnormal cells, you can diagnose the Bethesda classification depend on one cell. When you check the one cell, if the abnormal feature is mild, then you can say low grade squamous intraepithelial lesion. Low grade squamous intraepithelial lesion. So the new classification we call as LCIL, right? LCIL means low grade squamous intraepithelial lesion. So if the dyskaryotic lesions are moderate or severe, if the dyskaryotic lesions are moderate or severe, that is called HSIL, high grade squamous intraepithelial lesion. High grade squamous intraepithelial lesion. So this is totally different classification from the SIN1, SIN2, SIN3, because the SIN1, SIN2, SIN3 is a histological diagnosis. Why I am saying is, how do you say whether this is upper one third or lower one third or middle one third? We can't say. So if you want to say, then you need to take a piece of tissue from here, right? We take the piece of tissue from here and see under microscope, and then only you can say the lower third is abnormal, lower two-third is abnormal, entire length is abnormal. So always the SIN1, SIN2, SIN3 is difficult. So that's why now the new classification is LCIL and HCIL. LCIL mean low-grade squamous intraepithelial lesion. HCIL mean high-grade squamous intraepithelial lesion. That is depend on your dyskaryotic changes. So I'm really sure it's a bit difficult. That's why I'm doing very slow, right? So this is one of the difficult topics in gynecology. Please try to understand, and you will get more question on this as well, right? And also you are going to see a lot of patients on this, right? So LCIL and HCIL. So the LCIL is equal to SIN1, HCIL is equal to SIN2 and SIN3, right? SIN2 and SIN3, right? Now you all might have a wide knowledge about this cervical pre-malignant lesions. You might have a wide knowledge on this. Now you know the histology of the cervix. You know the virus, the HPV virus. Third one, you know what is happening once the viral infection occurs. Then you know what is this dyskaryosis. Now we studied, depend on the dyskaryosis, how we are classifying the abnormality of the cells as LCIL and HCIL, and previously SIN1, SIN2, SIN3. Now you don't have any question on this SIN1, SIN2, SIN3 as well as HCIL and LCIL. Do you have anything? Yes? No? Good. Now we are going to discuss the today topic. What is that? The screening. So here, if somebody got infection into the cervical transformation zone, the cells are going to be abnormal, your dyskaryotic cell, but unfortunately, these dyskaryotic cells are preclinical lesions. They don't have any symptoms. So patient will not present to you with any symptoms. Same time, as it is a nuclear changes, right? Most of the patients are having microscopic lesion. What you understand by microscopic lesion? You can't see by looking the cervix with your naked eye. Do you understand? So if you put the speculum and inspect the cervix might be normally looking. Then you will say, no, it's normal uterus, normal cervix. but still there might be microscopic lesions. Do you understand? So when you can see the abnormal cervix, when this pre-malignant lesion converted as malignancy, then there will be lesion somewhere here. Then only you can see an abnormal looking cervix. If you can see abnormally looking cervix, then you can take a biopsy from the abnormal area. Do you understand? From the abnormal area, you can take a biopsy and see under microscope whether it's normal tissue or abnormal tissue. Yes, this is an abnormal tissue. This is a malignancy. You diagnose and manage. But most of the time, these pre-malignant lesions are asymptomatic as well as microscopic lesion. So you need to do some intervention or test to find out the preclinical lesion, especially the microscopic lesion. So what are the ways? So what is the definitive one? As we discussed, you need to take the biopsy and see under the microscope, but practically you can't do that. So you have to do some screening test to check the abnormal tissue. Once you check the abnormal tissue, then only you can do the biopsy. So what are the screening tests available? One, visual inspection of your cervix. What do you think about the visual inspection of the cervix? Is it a good screening test to identify the pre-malignant lesion? What do you think? Yes, Kavinder, what do you think? Is it a good test?
Yes, it can be identified, no?
How?
Adding by the legal iodine or acetic acid.
Yeah, right. So that is different. I'm asking, just I'm looking Kavinder. Can I tell Kavinder is very fantastic and very good boy by looking? No, because there might be some microscopic lesion. How can I find that? So then what can I do? I have to do some additional maneuvers. So I can keep few bottles of alcohol in front of Kavinder and see what is happening. Then only I can say, yes, if he is not taking at all, then I can say, yeah, this is normal. So the visual inspection can be a screening test, but it's very poor sensitivity. Do you understand? Only you can identify if it is a lesion, if it is a macroscopic lesion. So you will not identify any of this microscopic lesion at all. Who is that? Right? You can't identify any of these microscopic lesions. So visual inspection is a screening test, agreed, but has less sensitivity. Agreed? Right. So how can you overcome this? You couldn't find the abnormality. When you see the cervix is it's normally looking cervix, but still there is an abnormal area here. So you need to find out the abnormal area. So then what you can do some additional things to find out the abnormal area rather than looking with your naked eye. So to overcome that, right? Bethesda classification. What is the name of the new classification? That is the name of the new classification, Bethesda classification, right? So the one screening test is visualization of the cervix. You should know very low sensitive and low specificity. Agree? So to overcome this, what you can do, you can apply some chemical mediators into the cervix to look or to find out the abnormal area. So there are two chemical mediators we are using to find out the abnormal area, microscopic lesions. One is application of acetic acid. Second one is application of leucoiodine. So what is the mechanism? So these questions I asked in the colposcopy notes. The mechanism of using the acetowhitening, mechanism of using the leucoiodine. So you have to answer for this question. So I'm going to explain you now, right? So what is the mechanism of using acetic acid into the cervical epithelium, right? So when you use the acetic acid, that acetic acid will remove the water from the nucleus. Temporarily, it will remove the water from the nucleus. Once that water removed, right, when the light waves are going into the cervix, right, what will happen? That light wave will reflect on the cervical epithelium. Agree? The light wave will reflect on the cervical epithelium. So if you see the normal cervical epithelium as well as abnormal cervical epithelium, this abnormal cervical epithelium has high content of proteins. The protein content is high. So if you have more proteins, right, after application of acetic acid, the water has been removed, dehydration. So the protein density is going to be very high. Okay. So due to high amount of protein, what will happen? The reflection of the light is going to be high. Good. The reflection of light is going to be high. So if you have more reflection, more lights are coming back, what will happen? That area is going to be why I am looking dark? Because I am absorbing most of the lights. Why somebody is looking fair? Because they are reflecting most of the light. Do you understand? So when the lights are reflecting more, that area is going to be whitish. So if you have an infection, if you have an nuclear abnormalities in the epithelium, when you apply the acetic acid, that area will be whitish. If the epithelium is normal, that area will not be a whitish. So after application of acetic acid, you can identify the nuclear abnormality. Agree? Yeah, simple. So that's why we are applying the acetic acid. That is called visualization of acetowhitening, VIA. Visualization of acetowhitening. That is second method. So inspection of the cervix is the first screening. Second screening, visualization of the acetowhitening area. That is second screening. So definitely, this method is going to be more sensitive and specific than visualization without anything. Agree? Yeah. Third one, we are applying the leucoladin. Right? Visualization, visual inspection of the acetowhitening, VIA. Second one is we are applying the leucoladin. Why we are applying the leucoladin is, when you see the cervical epithelium, that cervical epithelium has high glycogen storage. High glycogen storage. So when you apply the leucoladin to the glycogen, what is the color that is going to be?
Brownish.
Yes, actually the purplish brown, right? So it's look like a purple color, right? So when you apply the leucoladin to the glycogen, that is going to be look like a purplish color, right? So if it is a viral infection to this cervical epithelium, there will be more and more cell proliferation. So the glycogen storage will be utilized, right? So what will happen to the glycogen content in the epithelium of viral infected cells? Yes, it's going to be reduced. Good. Viral infection cell, the glycogen content is going to be less. So if you apply the leucoladin to the epithelium, if the epithelium has less glycogen, then that color is going to be orange. That will not be a purple. So when you apply the leucoladin, the cells stain as purple, you can say normal tissues. Agree? Because their glycogen content is normal. So the cells are stained as orange color. It means their glycogen content is less. So then you can say those are abnormal cells. Now, can you differentiate the abnormal cells? Yes. So this is another way of differentiating the microscopic lesions. Do you understand? So this is called visual inspection of leukoladin, villi. So now this is the third screening method. Visual inspection, one. Second one is visual inspection of the aceto-whitening, VIA. And third one, visual inspection of leukoladin. That is the third one. But what do you think? When you see with your naked eye, even after VIA, even after leukoladin, still your naked eye inspection might have a chance to have the mistakes. But if you use a camera with the magnifying effect, then you can easily identify the abnormal area than visualizing with the naked eye. Agreed? So if you use a camera with the magnification effect, then you will not lose any abnormal tissue. So to overcome this problem, we are using a camera to visualize the cervix with magnification, and you can see in a screen, in a big screen, and you can see a small abnormal area even after application of the acetoate as well as the leukoladin. So what is that equipment called? What is that equipment called? That equipment called colposcopy. Actually, colposcopy also one of the screening method, but the colposcopy is combined with the biopsy. That's why the colposcopy, we call it as diagnostic test. Always we are visualizing the cervix with the camera to magnify the abnormal area. That is your colposcopy. So don't worry, it's very simple. So we are just looking, then we are just applying the acetic acid, then we are applying the leukoladin. Sometimes to increase the sensitivity to detect the abnormal tissue, we are using a magnification camera with the screen. That is your colposcopy. So colposcopy also one of the screening tests. But only problem, arranging a camera and doing these things and take the biopsy, it's difficult for each and everyone. That's why what we do is, we are doing the rest of the screening method for all the patients. And if the screening test positive, so you have seen some abnormal area with your naked eye, then what you can do the test with the camera. And if you are really having abnormal tissue, take a biopsy. That's why the colposcopy, we call it as diagnostic test. Do you understand? Right. So these are few screening methods. In addition to that, we are having some other screening method. One is called pap smear. So what is pap smear? So pap smear, what we do is, we are taking the cervical discharge, right? We are taking the cervical discharge. Here you can see the cervical epithelium is secreting the secretions, right? The cervical secretions are coming, right? And cervical secretions will come through the cervical opening. So along with that, right? Along with the cervical secretions, here we know this is your transformation cells. These transformation cells has abnormal cells as well as normal cells, right? So these abnormal cells might exfoliate into the secretion. These abnormal cells might exfoliate into the secretion. So we know if we have abnormal cells here, those abnormal cells will exfoliate into the secretions. So this secretion might have abnormal cells. Agree? These secretions might have abnormal cells. So then what we can do is, right? What we can do is, we can take this secretion with the help of instrument called spatula. So I have mentioned a photo about the different type of spatula is in your notes. You can see, right? So the spatula will be like this, right? Right? Spatula. So what I'm doing is I'm putting the spatula into the cervical canal and I'm rotating to 360-degree. Right? Once you rotate the spatula into 360-degree, what will happen? These secretions will be on the spatula. Agree? This secretion will be on the spatula. Once you have secretion in the spatula, this secretion might have exfoliated abnormal cells. Once you take this secretion into the spatula, after taking this secretion into the spatula, right, what we do is we are making a smear into the slide. You just shade the secretion into the slide. Make a smear. Once you make the smear, you can take this slide and keep under microscope and see is there any abnormal cells. So if you have the abnormal cells, those cells will be exfoliate. That exfoliate cells will be formed as a smear. Then you can see under microscope. If you can see a dyskaryotic cells, then you can classify whether it's mild dyskaryosis, whether it's moderate dyskaryosis, whether it's severe dyskaryosis. Right? So if you can see a dyskaryotic cells, then you can say this patient is having abnormal cells in the transformation zone. She need a diagnostic test. Then you can do colposcopy. Do you understand? Do you understand? This is the mechanism of pap smear. This is the mechanism of pap smear. So the pap smear, we are looking the exfoliated abnormal cells collected by the spatula, right? Make a smear on the slide and see under microscope. But there are so many false positive results as well as false negative. Sometimes your secretion might not have exfoliated cell, but still she might have abnormal cells. That's why the pap smear can't be a diagnostic test. That is going to be a screening test. Right? So the pap smear we are doing in Sri Lanka since 35 years, every 5 years until 65 years. Do you understand? We start the pap smear screening since 35 years, every 5 years, 35, 40, 45, 60, so 50, 55, 60, 65. Until 65 years, we are doing the pap smear in well woman clinics. But in UK, the pap smear screening method is totally different. I am not complicating with the UK method because you won't get the questions on UK methods in Sri Lanka. So in Sri Lanka, we are starting at 35 years. Every 5 years until 65 years, we do pap smear. Do you understand? Right. So in pap smear, there are problems. So not only the exfoliated cells, right? Not only exfoliated cells, also there are some normal dead cells of the cervical epithelium. There are some blood cells. So you might have different unwanted cells. So as you have a lot of cells, when you make a smear, when you see under microscope, there are chance to make wrong diagnosis. Do you understand? Wrong diagnosis. Those are the problem with the pap smear. So the pap smear, the mechanism of pap smear is exfoliating cell, visualization of the exfoliating cells, right? So after making a smear, so we start the pap smear since 35 years, every 5 years until 65 years, right? So before we do the pap smear, we need to advise the patient, this is a screening test. right? So sometimes it might be positive, it might be negative. If it is positive, it doesn't mean you are having abnormality. If it is negative, it doesn't mean you don't have abnormality, but it's a simple screening method which we can do. And if it is positive, we may have to go for a colposcopy for the diagnostic test. Okay, somebody asked why not after 65? Anyone, can you answer for this question?
Sexually active, sir.
Yeah, there are two reasons. One, so after 65, most of the women are sexually not active, right? So, so the chances to get the HPV infection is less. So that is one. Second thing, so even when somebody exposed to HPV infection after 65, right? So the transformation from HPV infection to malignancy might take another 20 years. So maybe 85, that time patient might die due to some other reason. So the screening is not appropriate. If it is negative at 65, then it's less likely to develop malignancy after 65. Do you understand? So if somebody is developing cervical CA by 70, she might have abnormal tissue since 40 or 50 for a long time. Do you understand what I'm telling? So that's why we are not doing after 65. Okay, fine. Right. Right. So, so we have to advise the patient not to have this any medication into the cervix. So sometimes patient might put the medication into the cervix, right? So if the patient is putting some gel or maybe spermicidal agents, right? Or any intravaginal medication might alter your epithelium, right? Can we get through other methods rather than the sexual contact? No, it's usually it's a sexual contact, right? So we need to advise those things about the patient. Okay, who are the people need pap smear? Who are the people we need to do pap smear? As you ask this question, I am asking, who are the people need to do? So the patient who is never sexual activity, will you do pap smear? No, you don't need to. So the woman who is sexually active, who had sex once, yes, right? That is one. Second, if the woman has cervix, even after hysterectomy, right? If you do partial hysterectomy, so subtotal hysterectomy, if the cervix is there, definitely you need to do the pap smear. Even after the hysterectomy, for cervical intraepithelial lesion, or cervical CA, if you remove the cervix, still there is a chance of having malignant transformation into the vagina. So that's why even after the hysterectomy, for pre-malignant lesion or cervical CA, still you need to do the pap smear. That is called wall smear. That procedure is called wall smear. You are taking the smear from the vault, vaginal vault, not from the cervix, because there is no cervix. Right? So all the women who are in between 35 to 65 is an indication. Sexually active woman is an indication for pap smear. Women who are having cervix even after subtotal hysterectomy, you need to do the pap smear. Women who underwent hysterectomy for the pre-malignant lesion or cervical CA, you need to do the wall smear. Those are the indications for pap smear. How to do the pap smear? So any time of the menstrual cycle, other than the menstrual bleeding, patient should not have menstrual bleeding, right? Right? So what we can do is we can take the patient and put the patient into the dorsal position. You can't apply the betadine or any kind of antiseptic agent. What you have to do is you have to clean the vagina with a normal saline, right? And put the speculum, visualize the cervix, take the cervical secretion by the spatula, put the spatula, turn to 136, 360 degree, and Again, turn to opposite side 360 degree. Take the spatula out. Take the slide and make a smear. Once you make a smear, immediately you fix it into the alcohol. That is called wet fixing. That is called wet fixing. Put this, put the smear into the alcohol and examine the smear under microscope. But still, as we discussed, there are some disadvantages in pap smear. To overcome this pap smear, they found another method called liquid-based cytology. Right? We found another method called liquid-based cytology. Again, that is a screening method. But we can prevent some complication related to the pap smear. Right? What is that liquid-based cytology? Here, we don't use, in pap smear, we use the spatula, but in liquid-based cytology, we don't use spatula. We are using a cytobrush. So there is a picture about the cytobrush. You can see in that my notes. The cytobrush will be like this. There is a brush like this, right? There is a brush like this, right? So we take the cytobrush, put it into the upper part or lower part of the cervical canal and scrub it like this. Once you do like this with the cytobrush, all these secretion as well as these exfoliated cells will taken into the brush. Do you understand? You are collecting all the secretion and exfoliated cells into the brush. Once you take everything with the brush, right? So there is a fluid into the jar, right? Put your cytobrush into the fluid and you can wash it thoroughly. Once you wash, what will happen? All the secretion and exfoliated cells, right, will be coming into the solution. Right? Now you are having solutions here. The solution with exfoliated cells and the dead cells, RBC and everything. So after washing, you take this solution and you do centrifugation. Once you centrifuge, what will happen? These exfoliated abnormal cells are sediment in the lower part. So the lower part, all the cervical abnormal cells will be sediment. The upper part, your RBC, dead cells, low density cells are sediment in the upper part. Yeah, no lignocaine used inserting the speculum, right? Yes, you should not use lignocaine while you are inserting the speculum. You have to use the normal saline, right? So once you centrifuge, the abnormal cells will sediment in the lower part and the dead cells will sediment in the upper part. So then what you can do, you can remove the unwanted cell after the centrifugation. After removing these unwanted cells, now you are having a collection of exfoliated cells only. So in pap smear, when you make a smear, you didn't remove the unwanted cells. That's why you got more false report. Now, as you remove these unwanted cells, you are having only these abnormal cells. So you can inspect these abnormal cells here and your report will not be wrong. The sensitivity will be more. So over pap smear, actually the mechanism and everything is same, but liquid-based cytology has more advantage than pap smear. Do you understand? Liquid-based cytology has more advantage than pap smear because you can do easily, that is one. Second, you will have less chance to have the negative or inadequate sample results. Third one, your false positive or false negative results will be less. Sensitivity and specificity is high. That is third. Fourth one, after the pap smear, once you make a smear, that's the end. If you want another smear, you can't do because it's finished. But here you are having a cells collection. Whenever you want, you can make 2, 3, 4 smear. right? So you can do repeated smear formation. That is third one. Fourth one, if you want to do some additional test like HPV DNA or other viral or other STI screening, you can use this sample. You can use the sample for the other test. Do you understand? So there are so many advantages in liquid-based cytology, but we have problem with the liquid-based cytology. What is that? It's a bit expensive than Pap smear. There is a problem. So the Western world initially started their Pap smear. After that, they found the cytology, liquid-based cytology is best. Then they have shifted to liquid-based cytology. But still, in Sri Lanka, we are struggling with the Pap smear. We don't have the liquid-based cytology. But even though we are doing the liquid-based cytology, that also has less sensitive because we are checking only exfoliated cells. So that's why what now the in Western world they are doing is they remove the perhaps liquid-based cytology from the screening program. Now they are doing high-risk HPV DNA test. So what they do is they are taking the sample from the cervical secretions, do centrifugation. After centrifugation, you can take these cells out and check for the DNA, HPV DNA. If the HPV DNA is positive, what is it indicating? This patient has HPV infection. If the HPV DNA is negative, then the patient doesn't have HPV infection. So that is a bit more sensitive method to screen for the papillomaviral infection. So in Western world, now they are doing high risk HPV DNA assessment, but still we are doing Pap smear. Even the Pap smear screening program also not that much effective in Sri Lanka all over the world. Honestly say, how many of your mothers, your own mother and sister going for the Pap smear screening? No. It's not that much effective in Sri Lanka because it's not well aware among the population. So we are far behind from the Western world. That's why the Western world has reduced the cervical CA by 70% nowadays due to the screening as well as the vaccination program. So we need to work on that to reduce the incidence of cervical CA by screening. So please, if your mother not doing Pap smear, do Pap smear. That is actually good for your mother, good for your sister, good for your future wife. Do you understand? If your wife is more than 35 years, do Pap smear. Right? So you can prevent the infection, the cancer. So that's all about Pap smear, liquid-based cytology, and high-risk DNA assessment. And one more thing regarding the colposcopy, we have discussed something about the colposcopy. The colposcopy, colpo means vagina, scope means camera. Colposcopy means visualization of the vagina through the camera. So we are putting the camera into the vagina or outside the vagina after exposing to the cervical canal. So as I told you, that camera has power to magnify the image. So then you are seeing the cervix in the screen with the magnification. So then you can look the cervix. Is there any macroscopic lesion? If it is no macroscopic lesion, if you can't see anything macroscopically, then you need to find the microscopic lesion. For that, we are applying the acetic acid and see is there any whitish lesion. If you can see a whitish lesion, then you can take a biopsy from the abnormal region. If the after the acetic acid, if the cervix is looking normal, then you can apply the leucoiodine to check is there any abnormal area in the cervix. If the cervix is still abnormal, or if you can find out the abnormal area, you can take a biopsy, right? So you, as a undergraduate student, you don't need to know the colposcopic feature of L-cell, colposcopic feature of H-cell. So there are features. If you are a postgraduate student, I can teach you. There are vascular pattern, punctuation, right? So mosaics pattern, there are so many patterns. So you don't need to know that. right? So there are features in the colposcopy suggestive of L-sil. There are features suggestive of H-sil. So if the features are suggestive of L-sil, you don't need to take the biopsy because we know this is L-sil. If the features suggestive of H-sil, then we know this is a high risk of malignancy. Then what we do is we try to remove the entire transformation zone. We try to remove the entire transformation zone because as we know, the virus will target and get infect into the transformation zone only. So once you identify the high risk lesion in the transformation zone, what is your management is you need to remove the transformation zone. So how can you remove the transformation zone? You can cut the transformation zone, right? You can cut the transformation zone and take it off. Removal of transformation zone. That procedure is called large loop excision of transformation zone. That is called LLETZ. That is called LLETZ, large loop excision of transformation zone. So if you excise the entire transformation zone, then what you can do, you can send the transformation zone for the histopathological examination. So then histopathologist will see the transformation zone under microscope and say whether your transformation zone is abnormal or normal. If it is abnormal, how extent of this abnormal, whether it's malignancy or it's L-sil or it's H-sil, he will tell with the histological report. Do you understand what I'm telling? Right. So that is one, LLETZ. Second method to remove the transformation zone, what you can do, along with the transformation zone, you can remove part of the cervix like this. You are removing a big part of the lower part of cervix with the transformation zone as a biopsy. How do you call this removal? The biopsy is like a cone, right? So we are removing this part, completely this part, including your transformation zone. So that is called cone biopsy. That is called cone biopsy. So your cone biopsy, your colposcopy, right? Your colposcopy, right? Your colposcopy is a diagnostic test. You are visualizing the cervix with the help of camera after application of the acetic acid and leucoiodine. If the colposcopic features suggestive of L-sil, you can follow them. If the colposcopic features suggestive of H-sil, you can do the intervention. One kind of intervention is excision of the transformation zone. That is, either you can excise with the LEDs or you can excise with the cone biopsy. Another method for the H-sil is, if you have a lesion in the transformation zone, what you can do, you can destroy, you can burn out the transformation zone. You can ablate the transformation zone. That is called ablative procedure, right? So the transformation zone can be ablated or transformation can be excised. So ablation as well as the excision, which one is good? Which one is good? Ablation or excision? Which one is good?
Excision.
Why?
Because there is no risk of necrosis. Not necrosis. We can confidently say that we took all the epithelium and
Yes.
transformation
There are
zone.
two advantages. One, if you excised, you can take the biopsy.
Yes.
You can check under microscope, right? So if you ablate, there is no biopsy. You are just burnt out. You don't have biopsy, you can't confirm it. So the excision procedures are good because you can take a biopsy and you are confident, as you said, you are confidently, you can say, yes, I took everything out, because you can see whether the margins are free or complete margin is excised or not. But if you ablate, you don't know how extent you are ablating, whether completely ablated or still there are some residual products are there, we don't know. So if you don't know whether you completely ablate or not, if you have a residual tissue, from the residual tissue, there is a chance of recurrence. There is a chance of recurrence. Agree? There is a chance of recurrence. So always the excision process are, yeah, blind, is a ablation procedure is a blind procedure, right? So the excision procedures are best way to manage the cervical intraepithelial neoplasia. So I think we have discussed a very difficult and a bit complicated topic, right? But I think I did my level best to make you to understand. I don't know whether everyone understood or not. So if you have any question, you can ask me. Yes, Sanjeevan, do you have any question? So if you don't have a question, it means everybody understood everything. Yes?
Oh, no one understood completely.
Yeah, because it's really difficult, but if you understand from the basic, it's easy, right? So you might have some, of course, some doubt. So you go through the notes, right? There are some the empty pages. So I leave the lectures in YouTube, right? So you can access my YouTube channel, but I'll send a link through my all the group, so you can access and you can make clear. And of course, I know few students are in different groups, so you might get the same message repeatedly. So don't get angry. I'm really sorry because I can't send it separately. So I just select everything and send it. So then you might get same link. You might get it in different groups. So it's okay, right? So can you repeat the target group for the Pap smear? Yeah, the target group for the Pap smear one, the woman who is in between 35 to, so in Sri Lanka, in between 35 to 65 years, who is sexually active, or who had a sexual contact, definitely she has to have a Pap smear. That is one. Second thing, uh, if woman undergo hysterectomy, but subtotal hysterectomy, but she is having residual cervix. If anyone has cervix, yes, we have to do this Pap smear. Third one, even after hysterectomy, after removal of cervix, removal of uterus, if the hysterectomy is for cervical intraepithelial lesion like HSIL, somebody underwent hysterectomy, or malignancy, cervical CA, somebody underwent hysterectomy. After the hysterectomy, you need to do the wall smear to check the recurrence. And if, or say for example, if somebody had a stage 2B cervical CA, so then what you will do, you will give the radiotherapy. After radiotherapy, the cervical cancer will be cured or maybe reduced, but still they are having cervix. There might be a chance to have the recurrence. So then how can you identify the recurrence? Do Pap smear. Right? Patient receive treatment for the precancerous or cancerous lesions in cervix, need a Pap smear follow-up. Do you understand? Those are the indication for the Pap smear. So there are indication for colposcopy. I think I have mentioned in the notes, right? So it's there. Low risk lesion, how follow up after 6 months? Okay, if it is a low risk lesion, what we are doing is we are doing the Pap smear in 6 month time. So when you do the Pap smear in 6 month time, you can have 3 different results. What are those 3 different results? One, the low risk might resolve to normal. Agree? That is one. Second, low risk might persist as low risk. That is second. Third one, low risk might progress to high risk. Agree? Right? So you had a low risk lesion, right? So low risk lesion, you are repeating in 6 months. It could be normal after 6 months, or it could be low risk after 6 months, or it could be high risk after 6 months. There are three possibilities. So if it is a high risk HSIL, low risk LSIL now became as HSIL. What is your management? Colposcopy. Right? If the low risk is persisting as low risk after 6 months, then you can give another chance, another pap smear in 6 months. Again, it's low risk. So it means even after 1 year, the low risk lesions are persisting. The low risk lesions are persisting. It means your immune system failed to remove the infection even after 1 year. Agree? Even after 1 year, your immune system is not removing. So then it's an indication for colposcopy. Right? When you do the repeat test after 6 months, it's normal. But with the one negative report, you can't discharge the patient. You need to repeat another report in another 6 months. If you got 2 normal report, right? So you did after 6 months normal, again repeating after 6 months, it's normal. Now you can do the routine follow-up. What is that routine follow-up? What is the routine follow-up?
Yearly.
Yeah, 5 yearly for screening. So this time, so at 35 years, while you do, it's low risk. After 6 months, normal. After 6 months, normal. So then you can discharge them and repeat the pap smear at 40 years. Then repeat it at 45. Then repeat it at 50 years. Repeat it at 55. Then 60. Then routine follow-up. Okay.
Excuse me, in Sri Lanka, we don't do a routine screening for cervical cancer, right?
We do.
We do?
That, but people are not going.
And if a woman,
We do the screening through the Well Woman Clinic since 35, but people are not going because people are not aware about the screening system. So once you become doctor, you can make them aware. Once you become a MOH, that is your responsibility to do pap smear for all women who is in your MOH area. That is your responsibility.
so
Yes.
the frequency is 2 yearly or 5 yearly? If they have to go routinely.
Not
Screening.
5 yearly, 35, 40, 45, 50, 55, 60, 65. That is the frequency in Sri Lanka, not in the UK. If HSIL in pap smear, we go colposcopy. After that, what is the procedure? Can we do sample from biopsy or directly LETs? No. If it is LSIL in the pap smear, go for a colposcopy. If colposcopy features suggestive of HSIL again, then you do the LETs. After the LETs, then your follow-up is going to be same what we discussed earlier. So after the LETs, do pap smear after 6 months. See what is the pap smear. If pap smear is normal, repeat after 6 months and routine follow-up. If pap smear is again LSIL, then continue as LSIL management. If the pap smear again HSIL, then repeat the colposcopy again, like that. So even even in Sri Lanka, 40 years, if you get a normal report, you do it again in 6 months, right? No. When you do the routine screening, if the report is normal, then next routine screening will be at 45. If report is normal, next routine screening will be at 50 years. If it is negative results, every 5 years. If you have a positive results like LSIL or HSIL, depend on the LSIL and HSIL, we do screening. Very good lesson. The health promotion, that is very important, health promotion. So we are doing promotion for classes. We do a lot of promotions, but not for the health. Right? So I can tell you, if you are working as a doctor, you can do rest of the things. That is up to you. You can do class, you can do promotion, you can do private practice, you can do business, whatever the things you can do, but you do your work properly. That's the thing I can tell. So because especially as I am a local graduate, so I studied free of charge. All of my country people agree and accepted to learn from them, right? I studied free of charge for postgraduate, now became consultant. So without doing my ward work, how can I do classes? No, I can't. My first priority is to ward work. Second is class, because that is my interest. I'm doing as a second work. So I'm sharing my knowledge with my students. So few of students are now with me in Mulati Hospital. Today they came to the ward round with me. I'm teaching. So I'm doing work. Meantime, I'm teaching. That is my personal interest. Right? So without coming to the hospital work, without doing hospital work, without doing the proper work, how can you do the rest of the work? Don't do that. Right? So be sensitive. Your first priority is the patient. Second priority, of course, what I am doing, I'm not doing. So I'm not doing the business. I'm sharing my knowledge. I'm creating a good doctors to the nation, to the country. Do you understand? So always keep that in your mind. So you have to be a good doctor to the country. So so I'm really proud to produce a lot of good doctors. So now I got a new MO, 15th. So the way we are behaving in the hospital. So while I am working, so he is showing very interest and he's asking, sir, teach me. Always he is coming, whether he is on call or not. So today when I'm going to the night rounds by 6 o'clock, he's not on call. He's there. He's asking to teach. So when I'm doing the classes for the medical students who are doing, who came to the appointment here, your ERPM students, when I'm doing the class, or somebody present the case today, when he is presenting, that MO also came and sit. He is from foreign graduate. He's sitting and listening. What? That kind of enthusiasm. Everything is depend on you. So if you are a doctor, you should be a teacher. You should be a leader. You should be a guide to others. The way you are behaving, way you are working, others will follow you. Do you understand? Right? So a lot of people are looking at you. A lot of people are seeing you. A lot of people will take you as a role model. So if you do the wrong thing, then you can't be a good role model. Then the next generation will be wrong. Do you understand? Right? So very careful. So you all are doctors. You all are going to be a doctor. Right? So learn properly. I'm not doing Viva class. I told them, right? So few students get the permission from the director and they are doing appointments. I'll start the Viva class soon. That is different. Now, some few students, they are doing the appointments in a proper way. You can do. So I'm ready to teach you. If you come, yes, I will teach. That's up to you. So that is a different way. So this is a different way. I'm doing my off time. I'm teaching and getting some charge for the teaching. Not teaching for the money. Both are different. Okay, so if you have any question, you can ask. So otherwise, we'll wind up and have our dinner. Yes.
Thank you, sir.
Okay, welcome. Study well. So